Welcome back, students, to part 44 of our IPDRG Masterclass. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'm absolutely thrilled to have you here today because we're tackling some of the most critical and honestly some of the most complex areas in inpatient coding. In today's explainer, we're going to dive deep into the heavy-hitting DRG drivers of MDC03 and MDC04. We'll unpack the incredibly strict rules surrounding mechanical ventilation, and we'll see exactly how clinical documentation improvement, or CDI, literally protects a hospital's revenue. Okay, so before we push forward, let's just briefly ground ourselves. As we saw in our last lesson where we conquer the nervous system and eye disorders, precise documentation is just everything. It's the whole ballgame. The principal diagnosis sets the stage, right? But it's those secondary diagnoses that really dictate the severity of the case. Let's jump straight into MDC03. This is the category covering the incredibly diverse diseases and disorders of the ear, nose, mouth, and throat. The key DRG drivers here range from severe airway compromise risks, think things like deep neck space infections or severe epistaxis, all the way to highly complex surgical cases. And hey, here is a massive regulatory update you definitely need to know. Encounters for bone conduction, cochlear, and implanted hearing devices. They've recently been reassigned from MSDRG's 091 through 093 all the way over to MSDRG's 154 through 156. Staying on top of these kinds of shifts is exactly what makes you a top-tier coder. Understanding exactly how the MSDRG grouper logic splits these cases is absolutely crucial. Remember our golden rule of the medical versus surgical partition. If a procedure, say an open tracheus bypass, meets the CMS definition of a major OR procedure, boom, it instantly shifts the case into a much higher weighted surgical DRG. But on the flip side, if a patient comes in with a head and neck malignancy and only receives medical management, well, they stay strictly on the medical side. All right, let's shift gears to MDC04, the respiratory system. Now, this is a high-volume category that demands your absolute, undivided clinical attention. Here, we are dealing with really high-impact conditions. We're talking pneumonia, acute exacerbations of COPD, asthma, pulmonary embolisms, and acute respiratory failure. In this category, following the principal diagnosis coding hierarchy is absolutely vital for compliance. You constantly have to ask yourself, is the acute respiratory failure the true principal diagnosis here? Or does the underlying chronic condition like COPD or heart failure actually take precedence based on the specific circumstances of the admission? But let's look at the procedural side for a second. What would you say is the single most critical threshold that can massively shift the DRG weight for a patient in acute respiratory distress? It is the rule of timelines. Listen to this. Mechanical ventilation exceeding 96 consecutive hours, which is represented by PCS code 5A1935Z, very often triggers a major complication and comorbidity, or MCC. This drastically increases the DRG weight compared to a stay that is under 96 hours. It's literally a ticking clock that dictates both resource consumption and the final reimbursement. This exact coupling logic requires incredibly careful sequencing. Say an admission for pneumonia develops into acute respiratory failure with hypoxia, you must ensure the exact ventilation duration is documented perfectly in the discharge summary or the RT node. If the patient is ventilated for, let's say, 72 hours, well, that's under 96 hours, so it does not pull that massive DRG weight increase. Accuracy here is completely non-negotiable. Let's bring all this theory into the real world. We really need to look at the true cost of inaccuracy when it comes to clinical documentation improvement. This is where your specialized knowledge translates directly into hospital survival. Consider a real-world scenario. A patient is admitted for Streptococcus pneumoniae. The procedure is a bronchoscopy with lavage, and the patient has secondary diagnoses of COPD and hypertension. Now, if properly coded, this groups to DRG 193, simple pneumonia with a complication or comorbidity, which carries an expected reimbursement of about $8,500. But what if the coder's rushing and simply misses that secondary diagnosis of COPD? The DRG drops to 195, simple pneumonia without CC, and that cuts the expected reimbursement down to just $6,200. That single, missed secondary diagnosis results in a direct revenue loss of $2,300 for one single patient encounter. Multiply that by hundreds of cases a year, you can quickly see why clinical documentation specificity directly impacts the bottom line, and why undercoding is a massive, massive risk to revenue cycle management. To prevent this kind of undercoding, CDI teams have to push for exact terminology. Vague terms lead to lower payments and huge compliance risks. Instead of just writing COPD, which honestly tells us very little, the provider needs to document acute exacerbation of COPD to trigger that higher paying VRG weight. Instead of a vague sepsis, if the patient is actually in shock, they must document septic shock, which is an MCC. And instead of just unspecified pneumonia, we need the underlying cause. We need things like pneumonia due to aspiration or organism-specific strains like MRSA or gram-negative bacteria. And this is exactly why an experienced coder will step in and raise a formal, compliant CDI query to the physician. You don't guess, you ask. You say, "Doctor, please clarify if the documented respiratory failure is acute, chronic, or both." And then you track that formal query for closure to ensure the principal diagnosis matches the actual clinical reality of the patient. So, your actionable workflow as a coder is simple, but it is strict. Step 1, you always identify missing specificity in the chart. Step 2, raise formal queries for clarification when things are vague. And step 3, ensure the discharge summary aligns perfectly with the history and physical and the progress notes. Any discrepancies between these documents will almost certainly cause claim denials. Let's wrap up today's masterclass module and hit our key takeaways for these complex diagnostic categories. We've seen how the OR procedure partition completely drives the grouping in MDCO3. We've learned how the strict 96-hour mechanical ventilation timeline dominates those MSDRG weights in MDCO4. We quantified the real-world impact, showing how just one vague diagnosis causes a $2,300 revenue leak. And finally, we highlighted the absolutely critical role of formal CDI queries in bridging the gap between clinical care and coding compliance. But before we go, I want to leave you with a bit of a clinical puzzle. What exactly happens to the coding hierarchy when an acute respiratory failure leads directly to a systemic cardiac collapse? Which body system actually takes the principal diagnosis? And how on earth does the grouper handle multiple failing organ systems?
Well, we are going to decode that exact high-stakes scenario in Part 45 when we dive into the complex world of MDCO5, focusing on the circulatory system and cardiac DRGs. You absolutely won't want to miss it. That is all for today. If you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep studying, keep querying, and I will see you in the next explainer.